Excellent. Hello, everyone. This is Brendan Hayes with the National Hemophilia Foundation. Welcome to Hemophilia Treatment Now and the Future. This is a four-part series to help you understand more about all the treatment options currently available and on the horizon. Join us every evening, every Tuesday evening in October, in fact, at 7 p.m. Eastern Time to learn more. Next Tuesday, we will have our clinical trials overview. And then on October 26th, we'll have a session on communicating with providers. Tonight, we're going to be focused on innovative therapies basics, what you need to know. Tonight's speaker is nurse educator Angela Lambing. Angela has been a nurse practitioner for over 30 years with more than 20 years in bleeding disorders. Previously, she was head of an HTC in Detroit, Michigan for more than 15 years and worked in pharma for 6 years. She continues to provide targeted education to the community. Her experience covers aging hemophilia populations and is a clinical expert in pain management in the bleeding disorders community and is widely published in both these areas. She has presented locally, nationally, and internationally on a variety of topics relating to bleeding disorders and is currently working as a nurse practitioner consultant, continuing her work in these areas. We're all in for a real treat tonight. Welcome, Angie.
Well, thank you, Brendan, for that lovely introduction, and welcome to everyone who's listening today, and for anyone who chooses to look at or listen to the audio recording at a later time. What we're going to talk about today are the innovative therapies, some of the newer things that are coming down the pipeline so that you have a better understanding of what's going on. Before we get started, I just need to review that I don't have anything to disclose. But today, what we're going to talk about are some of those current and future options that are out there, how to best understand it, make sure you know the terms that go with it. But also, we're going to look at some of those benefits, limitations, and risks. And of course, with all new therapies, there are some potential unknowns that we have to address. And then we'll do a quick review of the clinical trials process just to give you an update. And I've got Brendan moving the slides for me. On to the next one. All right, we're going to start with the clotting cascade. And when you first look at this, it goes, oh my gosh, it looks very complicated. And I have seen even people in the medical field say the same thing. I once gave a talk about, oh gosh, I'm trying to think of what the topic was on. It was blood clotting with liver donors. And there was a lot of transplant physicians that were just overwhelmed when they saw this. But basically what we're looking at is you can see there's a lot of factors and proteins that are all interrelated. There are two different pathways. You'll see the intrinsic pathway. And if you follow it down, you'll notice that there is like the factor VIII and the factor IX, which is more with hemophilia. You'll notice on the right side, which is the extrinsic pathway, is factor VII. So with people who have deficiency with it. But the overall goal is for all of this to be working in concert to really form the fibrin clot at the end of the process. Now, you'll see there's the factor VIII and the factor IX. So when people have deficiencies, this is where that problem arises. So people with hemophilia will not have enough of the factor VIII or the factor IX, depending on which hemophilia you have. It doesn't mean that you don't form a clot. It just means that it takes longer for this whole process to work, to form that clot. But let's talk a little bit about some of the other products that are coming down the pipe, just to give you an idea. So for those for factor VIII and factor IX deficiency, what we have had in the last several years, many years, is standard half-life and extended half-life products. What are they doing? They're replacing the factor that people are lacking. So they're just replacing exactly that particular molecule. Next. And then, of course, we have what we call the factor VIII mimetic, which is really the bispecific antibody that we're going to be talking about later, but it does act on only the factor VIII at this time. And then you'll see gene therapy, which is currently in clinical trials. and becoming more available is targeting the factor VIII and the factor IX molecule. But then we also have other products like encapsulated therapy, which is going to be working for both the factor VIII and factor IX. And we have antithrombin 3, which is going to be the targeted with RNA interference therapy. And then lastly, there is the TIF P, which you see up in the top. Now, what's interesting about some of these factors and proteins, the thing that can be very helpful to all of you is that the normal range for all of these are 50 to 150%. So there are some that if you don't have enough, increase bleeding, but there are also some, if you don't have enough, increase blood clots. And that's where some of these new products are now starting to target, particularly on the right-hand screen, the TIF P and the antithrombin. So we're going to talk a little bit more in detail as we go along, and you're going to see this slide over and over again, and hopefully you'll become more of an expert. Let's move on to the next slide. So as we mentioned before, when we talk about hemostasis, we really want that balance between the factors and the proteins. We want the ones that help us clot to be balanced, and we also want the ones that help us bleed, that cause it, to anticoagulate, to be in a very even balance. So in the general population, this is typically what we see, a nice balance where clots are formed through the formation of thrombin in the process that we just reviewed. Next slide. But people, as we mentioned, who have factor VIII or factor IX, that they don't have enough of it. So when it's low, it increases that bleeding risk. Next slide. So how do we fix that balance? We give factor replacement therapy, such as what we talked about. We can give bypass agents, particularly those with inhibitors, which is a form of trying to make that process occur. And then there are also other non-factor replacement products, which specifically is the bispecific antibody, which we're going to talk about. Next slide. So let's just do a quick review of the current treatment options that are out there. Next slide. First of all, we have plasma-derived factor replacement. As most people may know, that revolutionized the care of hemophilia back in the 70s, where they were able to isolate the factor VIII protein and factor IX protein, where it was able to get exactly what you needed. So you were low in factor VIII, you got just factor VIII. And people stopped going to the ER for therapy, because that's when they were able to start do home infusion. But back in the early 80s, what did we come up with was our first recombinant factor products. And those are the standard half-life products, which were both factor VIII and factor IX. Now, one of the things that started to be a problem in the early 80s and late 70s, which some of you may be aware of, is the risk of bloodborne disease. And in plasma products, as well as some of the, in plasma products, there was the transmission of HIV and hepatitis. The reason for that is they had multiple thousands of donors that were in pooled plasma, but also that there was no viral inactivation processes that were in place at that time. So just to let you know that since they have now put those processes into place with viral inactivation, heat treatment, that sort of thing, as well as they're much more selective in their donors, there has not been a transmission of any bloodborne disease since the early 80s. What has been nice with the recombinant factor products that came up in the early 80s is that it has been man-made, so there's also been no risk of bloodborne disease. And then it was around 2013 when we saw our first extended half-life product that was targeted factor VIII. So if you look at what's happened in the last, our recombinant products have been out now for 40 years. That's pretty impressive, isn't it? But then, of course, we do now have additional products, and that is where we have other non-factor replacements. So that could be things like desmopressin, Amicar is another one that can help, and also the bispecific antibody protein that is also helping along that clotting cascade. Next slide. So we're just going to have a guess here, and you can use the chat portion of your screen. At this current time, how many different products are available to treat hemophilia A and B? So anyone just want to put in their chat what their guess is, and we'll let you know how many there are right now. So take a moment for that. What is your guess?
Well, Auntie, it looks like we have a shy crowd tonight.
I would say so. So I'm going to answer it for you. Okay, we got somebody who says 13. Okay, we're getting close. And then there's 2 and 1. All right, so we're getting some answers, but let's move on because I don't want to run out of time with some of the important things. But you may not believe this, there are 28. And when I think back on 30 years ago, when I first started in the hemophilia arena, we did not have nearly this many options. So this is really a very impressive way of identifying that we have lots of choices for patients to fit the right drug for them. And of course, there's more coming, so there's going to be more choices. Let's review some of those choices right now. Next slide. So if you look at factor VIII options, you can see there's the list of the plasma-derived, there's the list of the recombinant standard half-life products, there's also the recombinant extended half-life products, and then of course the non-factor options. I have always been of the belief that you have the right patient, the right drug, and the right dose. Because as we all know, no two hemophilia patients are alike. And I have seen this. You can pick any one of these products that are listed here. And if I gave any one of these products to 5 different people, I would get 5 different responses. So typically when you give a dose of factor, you're targeting like a 2% raise for every unit of factor. Well, not everybody gets that level. So if I gave 50 units per kilo, we would expect somebody to go up to 100%. I've had patients go to 75, I've had patients go to 50, and I've had patients go to 150. So no 2 patients really work the same way. So here's the option that you have is if you're working with a product and it's working well for you, great. But there might also be one that might work better if you're not getting a response that you're looking for. And that's what's nice is you have options. Next slide. But then there's a few factor IX products, and here they are. Again, the plasma-derived, which have been around and are still available, but also our standard half-life products and then the extended half-life products. So one of the distinct advantages with a factor IX is that obviously it lasts longer in the body than the factor VIII. And you know, again, there are still choices, and that same issue applies: right patient, right drug, right dose, and you know, hopefully to get that right response. And of course, there are more products coming down the pipe. Next slide. So we're back to that clotting cascade that I was telling you about. Again, as a reminder, here's the factor VIII and the factor IX, which if they're insufficient amounts will continue along the process to finish that fibrin clot formation, which you see at the bottom right of the screen. If somebody doesn't have enough of it, then the process is slowed or altered so that they still form fibrin, but it takes longer and it may not be as strong. Next slide. So let's talk about what are some of the benefits of factor replacement therapy. Well, one of the distinct advantages is now we're replacing exactly what somebody is missing. So if you're low in factor VIII, we know what percentage level you are. We know how mathematically how much to give, and we're treating it. So we're giving you exactly what you're missing. We were able to target that level of factor that we want to get to, typically, you know, up to 50 to 100%. It's been proven to be relatively safe. The major issue has been inhibitor risk, which can occur with all products. I believe in more cases, it's more genetically component rather than the product itself. And then, of course, we can target that peak, as we mentioned. It is easy to measure. We now have a very good test that can run, and if we let the lab know, we can typically get results within an hour. So you can see exactly that you've hit the target that you're going to. The other aspect, as I mentioned, these products have been on the market for 40 years. So we have a tremendous amount of data that has shown us how well it works in treating bleeds and managing surgeries. But there are some limitations. And the limitation specifically is the access issues. So we know it has to be given in an IV. So you have to find a vein. Well, in children, for anyone who is dealing with children, we know that this can be a challenge, because their vessels are so much smaller. They have more fat tissue, which hide them, so they're a little harder to get at. And so they have to, might have to have a port. And on the flip side, as our population of people with hemophilia are getting much older, we're also dealing with tired veins, which may mean it's harder to access them than they used to. Because let's face it, as we get older, those veins tend to be more fragile. They also tend to roll, and they're a little bit harder to get to. So people have to learn how to access and infuse. So if it's not the patient themselves, it's the parents or significant other. The other aspect is we know the amount of factor and how it's processed through the body is typically very predictable. So we target a level, we get a level up, and then the body uses it, and then it gradually goes down again. So one of the problems is that we have peaks and we have troughs. The problem is as it drops down low, if we hit a certain target area, it might be less than 1%. For some, it might be 2, 3, 4, or 5%. You can have a breakthrough bleed. So the biggest problem is we have to give it more often. But if by giving it in a prophylaxis regimen to keep that trough level from dropping too low, we've had patients do very, very well. One of the other aspects, though, with our extended half, products is that we tend to have what we call a long tail or a long trough. So it goes up, and then it takes its time going down. And then again, we're dealing with that same issue. How far out do we have to wait before it gets too low that could potentiate a bleed? But the advantages, say for somebody with factor VIII, where you might have to give it every other day, 3 times a week. With the extended half-life factor VIIIs, it's now maybe twice a week, so there's an improvement there. And then with the factor IX products, they were really able to extend that process a much longer. So I've had patients with factor IX products that had to take it every other day because their body used it up much more quickly. I had patients who did very well that could go every 3 to 5 days. And now with some of the extended half-life products for the factor IX, they're even able to go out 7 to 10 days. I'm not telling you everybody gets that. Again, it's that individual patient response that needs to be tested out. Next slide. So we're going to talk about the non-factor replacement, which is known as emicizumab or Hemlibra. My question to you, and we'd like you to put in the chat true or false. Hemlibra is used to treat active bleeding in patients with hemophilia A. Is this a true statement or a false statement? So we've got one false, we've got another false, and another false. So let's move on. And the answer is correct. It is false. And let's explain how that works. Next slide. So if you remember from the clotting cascade, you'll notice that factor VIII and IX were close together, and actually factor X was close too. Typically, factor VIII helps bind the 9 and the 10 to form this molecule, very much like you see here. So what the emicizumab has done is it has mimicked the factor VIII molecule. So it's an antibody that has been developed, which causes the bridging of the factor IX and the 10. And we call it a bispecific antibody, bi meaning two, because it binds specifically to both factor VIII and IX. And what it does is it raises levels in a more consistent fashion on the factor VIII molecule so that it helps to prevent bleeding, but it does not actively treat bleeding. So by keeping our levels up, you tend not to bleed. And that's what the emicizumab does. Next slide. So again, this is in that clotting mechanism I was telling you about. You see it targets just only the factor VIII, but there is another product that's on in the pipeline being explored. And right now it is not used for factor IX. Next slide. So here's kind of a depiction of it. You'll see the factor VIII looks very similar, and it helps to bind that factor IX and 10, which you see on the right. And if we push the button for the next diagram, you'll see that the bispecific antibody kind of does a similar thing to allow the completion of the clotting cascade. Next slide. It's been approved only for factor VIII, again, to prevent bleeding. It's now been approved for children and adults. And I have to tell you, it was a real game changer for patients with inhibitors because they did not have a lot of options. And we have found that it's worked very well for them. So people with inhibitors to factor VIII products, they had a lot of breakthrough bleeding with the products that they were using. And this was a real game changer for them. The other aspect that's kind of a positive, although not everybody may feel this way, is how it is used. So it is now, instead of given IV, it's given subcutaneously in a small needle under the skin. So very much like insulin. Now, some people think, oh, well, this is different, I can't do it, but you don't have to access a vein, and you pinch an inch and it goes right into the tissue. As a nurse, it's the easiest way to give medicine, I have to tell you. Now, how often is it given? Again, it's very dependent on what the dosing regimen is and what your treatment center and you have discussed, but it could be weekly, every 2 weeks, or even up to every 4 weeks. And again, it really depends on your own personal response to how this medication has worked for you. Next slide. But let's look at some of those improvements. I think it's an easier administration. And I think if you were ever to talk to someone with a young child where there might be an IV access issue, this is actually a game changer for them. Again, it provides that steady state of factor VIII. So once it binds them together, it's a steady state. So it really eliminates those peaks and troughs where if we get too low, there's that potential for breakthrough bleed. So, and as I mentioned, it's been great for patients with inhibitors, but there are some limitations. And those limitations are that, again, it's limited to people with hemophilia A. We also have to remember that we still need factor. So if somebody is having a major surgery or if there's a major traumatic event, they're going to need to have a little bit of factor VIII to top them up to make sure that they don't have any bleeding. The other problem is that we don't really have a good lab test to monitor this. So it doesn't, like if I were to test a factor VIII level like I would with the previous factor extended half-life and standard half-life products where I give a dose, the level goes up, I see where I'm at, I know where I'm good. If I did those same tests, we would have a variable response. And in some cases, it would give us false levels where it might be higher than we think it is or lower than we think it is. So the other problem too is that when it first came out, is particularly with inhibitor patients that were using other types of bypass agents, they realized that using them together increased the risk of blood clots. Now they have since address that issue. There's a black box warning that FIBA in particular is not used when inhibitor patients are using Hemlibra, and I believe they've resolved that particular risk that has occurred. Next slide. Let's talk more about some of those future ones. So when we talk about why do we come up with new factor products? You can see that there's a lot of issues that we want to explore. So we're always looking to make sure that it's safe. We want it to be effective. And if there's an easier way to give factor for it to work for patients, we're always game for that. You recall they've minimized volume. They've also changed, reconstitution devices, anything to make it simpler. But again, what is our major goals as well is to decrease or eliminate bleeding, which in turn will minimize that joint disease because we don't want bleeding into the joints. And then, of course, can we use less factor if there's other opportunities out there? And then we want to really improve overall quality of life. So the idea is that we want to improve the health of all of our patients. Next slide. I'm going to talk just briefly about the clinical trials overview. I know that there's a session next week that goes into it in much more detail, but let's just do a quick review. And the FDA is involved in all products that are used on patients and people in general, because the idea is that they're identifying a specific treatment or prevention and is it safe and effective. So there are different stages of the process. We look at improving the disease, and it's also very much evidence-based, meaning that medical practice is guiding how this therapy that we're looking at is going to proceed. Next slide. You may think that FDA is the only body that's involved in clinical trials. And as you can see, there's a whole lot more people involved and a whole lot more organizations. And the main aspect is to make sure that the individual is safe during the process. So there's a lot of monitoring, privacy, and all following specific guidelines and protocols. Next slide. So let's start with the first process. Preclinical is really when it gets started in the lab. So they're using animal models, they're testing it to see how it works on an animal, to see if it's effective, if it's safe, whether there's any toxicities or side effects they need to look at. And then we move on to the next, once they've kind of worked all those bugs out, into phase 1. And phase 1 is where they give it to a small group of people for the first time, and really to look at the safety, the dose, making sure that they're targeting that dose correctly, but always watching for side effects. And then we move on to phase 2, where they'll take into a group, larger groups, and usually the ones affected by hemophilia in this particular case. But again, you'll notice they're still monitoring for safety at all steps of the process and making sure that it's effective and that it's going to do the job that they think it's going to do. And then they move into phase 3. Phase 3 is when they're using a significant number of groups affected by the disease, and they're continuing to gather data along the way with a larger subset of population people to make sure that it's effective, that it continues to monitor for side effects. And typically in phase 3, what they'll do is they'll take another product that might be similar and they'll do a head-to-head comparison. So they'll give 2, we call them arms, where you might have, as an example, 100 patients. And again, the FDA determines what that number is. They'll put 50 on one particular drug, 50 on the trial drug, and they do the exact same thing. And then they compare them to see if they are as effective or better, or if one is better than the other. But we're not done yet, because then the FDA comes into play. You want to hit that button. And that's when they say yay or nay. And you may recall that there's a current gene therapy trial that was in clinical trials, and it was halted. It wasn't halted in the sense that they said, no, it's not safe. All the FDA wanted was more data. So they had to continue to collect data per the request of the FDA to continue to show that it was safe and effective before they released it into the market. And once it gets released into the market, it now goes into what we call the phase 4. And we call this post-market analysis. And this occurs with any drug. So even if the drug has been on the market for a year, 5 years, 10 years, if somebody has a problem with that drug or a side effect, it needs to be reported to the company that made it so that they can continue to collect data to show the ongoing potential side effects and efficacy of the drug. So it's important that if you have a problem, you need to let your provider know so that they can report it. And then, of course, they're finalizing how it's used and how much it's going to cost. But look how long this can take. And there are many drugs along the way that never make it all the way. And a lot of time and effort is put into that process. And you can see there's a lot of people involved as well. Next slide. There's also an organization we call Core Heme, which really looks at, they're looking at the gene therapy, but I believe that these same practices are being used for all of the newer products that are coming down the pipe. So what they identify is they identify a set of outcomes that they want to evaluate to make sure that it's consistent across the board and it's safe all along. So for instance, when we look at the frequency of bleeds, and you'll recall when we first started with factor VIII and factor IX products, that was the annual bleed rate, ABR. What are we watching for? And then we were looking at levels, and then we're monitoring for pain issues. And then we're also getting involved now in some of the mental health issues and costs of the healthcare system. But you'll notice that we're also exploring some of the additional events, such as some of the short-term issues, such as liver toxicity, possible immune responses, blood clot risk. And then we're looking at the long-term issues. And then, of course, making sure that there's no cause of death related to the products in question. Next slide. So we're going to review some of the newer products that are coming down the pipe. And just to give you an idea, look how many there are. Now, look how many gene therapy products that are currently in clinical trials. 15. That's a lot. So let's talk a little bit more about what each of these do and how they work so that you can have a better understanding. Let's move on to the next slide. Again, we're talking about that balance between bleeding and clotting. So if somebody, again, has factor VIII or factor IX deficiency, they don't have enough, which means they have an increase in bleeding. Next slide. So by correcting that process, in the past, we've given factor therapy, non-factor replacement, but this is where gene therapy and the encapsulated cell therapy, or ECT, is coming into play. And we'll talk a little bit more in the coming slides here. Next slide. So let's talk about gene therapy. It's a way of transferring a particular corrected gene into the body so that it triggers the body to make that particular product on its own in a sustained way. So we call it gene transfer. We're going to go a little bit further into detail. If you hit the next slide. So again, this is targeting factor VIII and factor IX, which is it's nice that it's not limited to one or the other. Next slide. As I mentioned, there's a lot of different gene therapies in clinical trials, and there are a few that are looking at inhibitor patients. So, if you're not sure if this is something that you're interested in, you can talk to your treatment center. You can also go onto clinicaltrials.gov, and just put gene therapy and hemophilia, and you'd be amazed at what will come up. Right now, they're limiting it to males. They're over the age of 18. I think there might be a few that are might consider a little bit younger age, and you may ask why it's not younger. And typically the liver does not mature until adulthood, and since gene therapy targets the liver, they have chosen to wait until they're adults. They have to be healthy. What that means is no active liver disease or other comorbidities. Now, that doesn't mean that if you have HIV, Some clinical trials are, as long as the level's stable and it's well managed and controlled, you may participate in a clinical trial. But again, some accept it, some don't. So you have to navigate that with your treatment center. And the same goes for hepatitis C. So if it's well controlled, or if it's been treated and ongoing negative viral loads, there's a chance that, that particular gene therapy trial may be able to accept that particular person. And of course, other healthy issues. So you can't have other things like diabetes, hypertension, and, but again, you have to look at the enrollment criteria. The other aspect is because gene therapy use what we call a vector. That is a package that kind of holds that gene while it goes into the body. And it's usually a virus that they've taken out the viral component, continued with that shell that protects it. And why do they use it? Because the body accepts it readily. But if you've ever been exposed to the one particular virus shell that they're considering, you may not have a good response. But that doesn't mean that you can't participate in gene therapy, because they're looking at different types of viruses to be used as vector. The other aspect of it is that this is, once it's made and prepared, it's in an IV infusion. You typically are given it under supervision. It takes about 30 minutes to infuse. It's only given once. At this moment in time, we don't know if people can be redosed, because we're still in the early stages of it. And unlike factor, you get factor, your body uses it and it's gone, you can get it again. Gene therapy, it doesn't occur that way. Once you give it, it's there and you can't take it back. Next slide. So let's look at it. First, they develop that working copy of the gene in the lab, either the factor VIII or the factor IX. Next, they develop that vector, and that's an adenovirus typically, and it's sort of like a box. So they put that working copy of the gene into that box to protect it, and as it gets ready to go into the body. And then they put it into an IV solution where it gets infused, as I mentioned before. And if you hit the next button and it enters the body, it typically targets the liver. So it heads towards the liver where it gets released, and the liver takes over those new genes to start working and doing the job of the factor that your body lacked. And then so it tells the cells to produce that protein and do the job. And then it produces the factor. And then that vector, or that box or virus that was previously used, it gets eliminated through the body through bodily fluids. Let's talk a little bit about encapsulated cell therapy. And this is pretty early in its stages of therapy. There is a clinical trial that's been put on hold right now because they're looking for a little bit more data. But basically, they're engineering specific cells to make the factor, and then they're put into specially designed capsules. So it's not a virus like what we talked about in the gene therapy, but a specific capsulated molecule that is implanted in the body, typically in the abdomen, where it gets released in a sustained, consistent way so that the factor VIII or IX gets released into the body. We're still in early clinical trials with it. Next slide. And you'll see that this also can be used for factor VIII and factor IX. So by releasing sustained levels of factor VIII or factor IX, it helps to complete that clotting cascade down to the fibrin clot that you see in the bottom right. So again, as I mentioned, early stages, it's only in phase 1 or 2. Remember, we had phase up to phase 3 and 4, so they're still working on it. Again, we're sticking with 18 years of age and older. You may ask, why aren't we using females in the clinical trials? And currently it's because the numbers are very small, and it's easier to try to get a more homogeneous population where you're dealing with like all males, all with severe hemophilia, that sort of thing. One of the things with this particular therapy is they have to be withdrawing from factor VIII prophylaxis during the time of the study. The idea by these capsules, which is surgically implanted, and it's a fairly minor procedure, is that they are protected from the immune system and they stay there and produce those clotting factors. They're now suggesting that it is possible, as the therapy waxes and wanes, that they might be able to redose people. So there is some promising opportunity here. But again, we're still working on it. And this particular study is on hold until they get a little bit more data for the FDA. So here's another picture of it. You'll see there's the human cell where you get that particular gene that they want to develop, either the factor VIII or the factor IX. They have that particular capsule, which is kind of shielded, lets the proteins out, but keeps everything protected. They put it in a special solution or preparation. I'm not sure how that's going to look yet. And then it gets placed under the tissue into the abdomen, where the body starts releasing, allows it to be released and circulate throughout the body. So pretty exciting stuff. So let's talk a little bit more. If you recall, as we mentioned, people with hemophilia A and IX, A and B, they lack that factor, so they tend to bleed more. But now we're going to look at some of the clotting factors to see if we can balance that out in another way. If you want to hit the next button, we'll move on. So just there you'll see, and that's where the AntiTiff P and the RNA interference therapy comes in, and I'll explain that in the next coming slides. So let's talk about the anti-tissue factor pathway inhibitor known as TIFF P or AntiTiff P. So typically the tissue factor it helps block the initiation of blood coagulation. So we want to balance that right amount. So as we know, too much factor can increase clots, too little increase bleeds. The same kind of thing occurs with TIFF P. But the difference is if the levels are too low, you can clot. So what they're trying to do is inhibit that pathway to allow that level to come up a little bit so that they can balance that therapy out. So again, it's to decrease that activity, to allow that, thrombin to be generated and prevent that bleeding episode. Next slide. And you can see in the top right where it just highlighted is where it's affected. So again, it's that balance, too much, too little, and trying to figure out exactly how much is going to be given that's going to counteract that factor VIII and IX to create that balance so that we can form that fibrin clot. Next slide. And there are a couple that are in clinical trials. You'll notice they're now in phase 3. Again, we're still dealing with hemophilia A and B, but the difference is it doesn't matter what severity. You don't have to have severe hemophilia. You can have mild or moderate, can be with or without inhibitors. And because it's not targeting the liver like the gene therapy is, they now are enrolling younger populations. Again, this is easy to administer because it's given subcutaneous. With a small needle, and you'll notice the difference between the two products where one is daily and one is weekly. So back in March, they did kind of hold off because they did have a couple thrombotic events. And if you recall, too much, too little of different products can increase that clot possibility. And I think they had to tweak it a little bit, and now they're back on track. So let's move on. So let's talk about the RNA interference therapy. And what it does is it targets antithrombin. Now, antithrombin is a procoagulant. So if somebody has a deficiency or a low level of antithrombin, they can clot. So people with factor VIII and factor IX, low level, they bleed. Antithrombin, it's the opposite. Too little a level and they can clot. So what we're trying to do is really balance again that out. So when by interfering with the antithrombin, it helps to decrease it a little bit to a manageable level. We don't want to go too low because they'll clot, but to decrease it to balance that out. Again, let's move on. So they are in phase 3. So, as you recall from the clinical trials, they're getting larger numbers. We are looking at pediatric and adults. They are indicating moderate to severe hemophilia A or B with or without inhibitors. But again, they're not allowing hepatitis, but they are allowing HIV if it's well managed. This is given subcutaneously and it's given once a month. So, there's a lot of different therapies out there. And the question then becomes, how do you know what's right for you? And that is a conversation that really needs to take place with you and your provider, because they know you better, your body, and what your opportunities are. You also have to look at what those restrictions are, those limitations. The other aspect is if gene therapy isn't the right option for you, or if it didn't work and you did try it, can you get another gene therapy? And that's a conversation that needs to be had. And, the people have been involved in multiple trials over the years, but there are specific requirements that are part of the FDA process where you have to be a part. If you did one trial, you have to be so many weeks and months before you can try something else. Again, you have to have the conversations. How safe is it for your situation? And what are the short-term and long-term side effects? The thing to keep in mind when you are involved in any clinical trials, especially with these products right now, you're in for the long haul. This is not like I'm just going in, I have an office visit and I'm out the door. We're talking about collecting data for 5 to 10 years. So right now with gene therapy, they've been able to get sustained levels above 50%. Now, 20 years ago, they couldn't. They were only getting these modest levels, but now once they figured out the vector, they were able to get up to that 50%. Not everybody gets there, some do, but the question is for how long? And only way to do that is to participate in the trials and collect the data. And again, you have to be committed to helping out and being available and follow the plan. Next slide. So here are just a review of different products that are involved in different clinical trial stages. And you'll notice that there's still some factor 8 and factor 9s that are still being considered. But also look at that in phase 1, they're looking at a longer acting factor 7, which is another issue that needs to be addressed because currently factor 7 products have a very short half-life, 2 to 3 hours. So if we can get something longer to help those people, that's great. Next slide. So we are going to now test you. So let's go back into that chat. If you could answer these questions for us. The first question is, the fluctuation of factor levels, peaks and troughs, is a benefit of factor replacement therapy. Do you consider this a true or false statement? So we've got one answer that's false, and you are correct. Let's move on. That's one of the disadvantages, actually. Next slide. Because with factor, the body, absorbs it, uses it, and then it goes back down. So that's what makes it hard to manage your bleeding disorder, because you can get that trough that can increase the bleed risk. Next question. RNA interference is designed to target antithrombin, a protein that puts the brake on bleeding. True or false? Okay, I got a false. And the answer correct is false. So what we want to do is to decrease that amount of antithrombin, but not too much, because if it goes too low, we can increase the clot formation. So it will promote the generation of thrombin to naturally rebalance that process. So it does remove the brake on clotting a little bit. Next slide. which are true about emicizumab, known as Hemlibra. It is a bispecific antibody. It mimics the action of factor VIII. It bridges 9 and 10 to allow the coagulation process to continue, or all of the above. And the answer is all of the above. And we can move on. Once I receive gene therapy, I never have to take factor products again. True or false? And the answer is false, because it helps to elevate those levels to try to reach a sustained level, but not everybody gets there. And even if you have an injury or a surgical intervention, you're going to need factor to top up. And then the other aspect with gene therapy is we don't know how long those levels are being maintained, hence the reason for the long-term studies that we're doing right now. What is the last phase of the clinical trial process before submitting to the FDA? Is it phase 1, phase 4, phase 2, or phase 3? And the answer is phase 3. If you recall, that's when the FDA says, yep, we got all the information we need, you're good to go. Phase 4 is that post-marketing where they continue to collect data for years to come. Next question. I think if we have. At this point in time, I hope that I've answered all of your questions. What I'd like to do is turn this over to Brendan, who is going to just review some of the resources that NHF has so that you can learn more about the therapies that we've talked about and have access to more information. On to you, Brendan.
Great. Thank you so much, Angie. This was really interesting, and I'm hoping that you guys all learned as much as I did. I will tell you, we have once again a really smart audience tonight. So I actually put in the chat a link to all of these resources so that you all will have the opportunity to go in and look and see all of the fantastic educational materials we have on the NHF website. So we've got frequently asked questions. We have a gene therapy glossary. We have a really fun little 3-minute explainer video on gene therapy, and it really breaks it down and makes it simple to understand.
It's a great video, yes.
Thank you. We have a variety of webinars out there too, where we've had different providers go into more detail on some of these therapies and technologies, and that's all out there for you to access on demand. Wanted to also highlight NHF's Community Voices in Research. You can also access CVR from our website as well. And my mouse has been sticking tonight, so sorry it's taken me a while to go through, but in summary, advancements in treatment options are going to continue for the foreseeable future. That's really exciting for all of us. But it's important that we stay up to date. Things are moving quickly, and even between your yearly HTC visits, things could change. So it's really good to stay on top of things, and you can do that by going out and looking at some of that information on our website, as well as staying up to date with our communications. So, seek to learn more about existing and future therapies. Talk to your provider so that you understand what's going on, and be prepared to ask those questions, and read about clinical trials that are underway. Recognize that these are long-term commitments for these gene therapies and some of these other innovative therapies in clinical trials, and consult your provider to continue to learn about the risk and benefits of these therapies so that you can make the right decision about your treatment option. And again, visit our website for more information. And with that, we would like to thank our partners in education. We are so pleased that you were able to join us tonight. We touched a little bit on clinical trials in the last couple of weeks. We're going to actually speak more in detail about clinical trials next Tuesday night. So if it's something that you're interested in, participating in a clinical trial or just learning more about it, it's really a great session to help you learn more. Angie, thank you so much for doing such a great job for us tonight. We really appreciate you and wishing you all a fabulous evening. And we hope to see you again next week. Thanks so much, everyone.
Thanks, everybody.